Good morning, everybody. Our topic for this session is clinical decision support. So I thought I'd start with a question. What exactly is it? Well, if you've ever struggled to define CDS, or if you have your own definition but find that others disagree with you, or if you've never even given it a moment's thought, you're not alone. That's the subject of this interesting paper. One of the authors is Dr. Siddig, who's here today. And in the paper, the authors argue that this lack of consensus on the meaning of CDS is important, and that has a negative impact on every aspect of creating effective CDS tools. If you think about it, the same type of thing, excuse me, I'm out of breath from running here, is true in other areas of HIT. For example, define EMR usability. Well, from the subject responses, they identified three categories of CDS: alert, workflow, and cognitive. In addition, they describe CDS that can be explicit, where the user is aware that the system is intervening in some way, or implicit, where it's working in the background. Well, here at CBMI, we're developing CDS tools to help manage the care of patients based on some diagnosis or condition. And from that type of work, if you were to ask us for our definition, we would probably say it's all of the above, and maybe even a little more. And that's essential to apply all of these different approaches in the right combination to create effective tools. And the reason we think that way is from working with two of our researchers, Drs. Robert Grunmeyer and Alex Fix. In 2005, they developed something called the Care Assistant. It's a programming framework which expands the CDS capabilities of our EMR and does so through real-time data mining, a very powerful rules engine, and our ability to automate and customize the EMR in many different ways. There have been 6 Care Assistants developed to date, 3 more are in progress. They're all parts of funded studies. Our most recent Care Assistant is by far our most complicated, and that's because it's dealing with the care of complex patients, premature infants. The Preemie Assistant was developed to help our primary care practices manage the health of these children during their first 2 year lives and manage their multiple risk factors. Excuse me. This is a screenshot of the Preemie Assistant. It appears in what's called the Visit Navigator of our outpatient EMR, and it presents to the physician a summary of the patient based on 5 clinical issues important for preemies. And it does so in a way that combines these different CDS approaches in different ways. For example, the first issue is growth and nutrition. This is fundamental to the health of these patients, and the system therefore presents an assessment of the child's growth. If growth is low, it provides an alert. It then supports that alert with cognitive and workflow tools, shown here. At the top of the screen, we analyze and present growth with far more precision and detail than you could get from looking at the 3 different growth charts, and we always use the right growth chart for preemies. That's also a problem. Below that, we have a nutrition calculator where the doctor can work with the parent to calculate the current feeding, come up with a new feasible feeding plan to help improve the child's growth. From that, we now support workflow and patient education. We generate the right mixing instructions for the parent. We insert summary text both for the parent in the patient instructions and for the doctor in their progress note. Back to the main screen, the next 3 issues are development, ROP, and blood pressure. They're each handled again with a different combination of CDS approaches. There is no one-size-fits-all CDS approach for any of these issues. I think that's interesting and important because each has slightly different forms of information and therefore different tasks. The 5th issue is respiratory syncytial virus, or RSV. This is by far the most complex issue we address, so the rest of my presentation will focus on our approach here. A little background. For many premature infants and other infants, RSV is a seasonal virus that can lead to hospitalization or death. It's very serious. Fortunately, there is a drug called palivizumab, or its trade name Synagis, which can help prevent RSV. However, identifying patients at risk for RSV is very complicated. This is the American Academy of Pediatrics policy statement that outlines the at-risk criteria over 3 or 4 of its 10 pages. So the challenge here is how do we translate the information from this document into our Care Assistant rules engine? Well, I'm not going to talk about that at all because that is the subject of our next speaker, Dr. Jeremy Michael from the Glides group at Yale. We use their tools and approach to do this translation, and they're also a funder of this project along with the NIH. So skipping way ahead, kind of like a cooking show where I can just pull the souffle or something out of the oven, it's all done. We have now programmed our rules engine with the RSV Synagis rules. This is a ready diagram of those rules, and what this diagram seems to get across is that these rules are very complicated, and they are. Something like 30 different variables from all over the EMR applied to 110 different decision points. Overall, the Premium Assistant uses 200 or so patient variables applied to 1,400 rules. There's a lot involved in the care of these patients. Well, now that we've identified all the patients at risk for RSV, our work is done, right? We'll just give them Synagis. Unfortunately, we're not even close. There's this massive workflow beyond the alert, that's our catchphrase, that has to be addressed. There's two parts to this. First of all, Synagis is very expensive. $1,500 per dose, 5 doses per child. Therefore, there's a lot of paperwork in the insurance approval process. Once approved, we now have to manage every aspect of ordering, delivering, administering, and tracking 5 doses over 5 months and do that on time every time. Well, each of our practices, this workflow is managed by, for the most part, a single nurse. They actually call them the Synagis nurse, and though they have many other responsibilities. These nurses tell us that managing this workflow can take between 10 to 20 hours per patient, and some of our practices, especially in the city, have 50, 60 patients or more. So that's an awful lot of work, and we wanted to help. Your next question might be, how are they using the EMR to support this workflow? Well, the answer is they don't, because they can't. I'm not trying to be critical of the EMR vendors, but if you look at the requirements in this type of workflow and compare it to the requirements they seem to have applied to the current CDS tools and other tools, there are a lot of gaps. In addition, you might think, well, RSV Synagis, that's pretty odd and unique and extreme, but there are actually many other scenarios in healthcare that have the same type of workflow and also need to be supported. So without EMR support, what do they do? What do they use? Our nurses use paper, shadow charts. At each of our practices, along with the Synagis nurse, is the Synagis binder, a 3-ring binder, sometimes 2, full of all kinds of paperwork and forms and a lot of protected patient information. So our challenge here was not just replace the notebook, but to exceed its capabilities. Oh, I need to skip over this, sorry. So we did that by applying 2 different integrated tools. This is the first one here. This is essentially the Premium Assistant, but for our Synagis nurses. It also appears in the EMR for the nurse, and I'll walk through what's going on here. At the top of the screen, we present to the nurse the analysis of applying this child's data to the RSV Synagis rules. Seems very simple here, but we know it's very complicated. Here we have some fields for submission and insurance company. It's important. Well, if we're going to submit the child to the insurance company, what do we need to do next? Anyone have a guess? Fill out forms. The insurance companies all have a different form for this, but yet they seem to ask for the same data. Look closely, it's about the same 30 or 40 fields that we identify in our rules. Why? Because they're reading the same document. So instead of a manual chart review, which the nurses used to perform, think again, 30, 40 variables, 50 patients, we run the chart review for them. This feature alone made our developers superstars in the nurse's eye. Once we submit them for approval, we have to track approval. Sadly, that often includes an appeal. That's right, for some of our patients, our nurses have to do all of this twice. Once approved, we now manage the dose administration process. This is copied almost verbatim from the Synagis notebook, but we add, again, cognitive support. We automatically calculate the date range for all 5 doses for them. From that, we can help them by adding information about scheduling, so they can schedule the doses, the appointments for all 5 doses. We even project the child's weight using our weight rules, because you have to order Synagis in advance. They won't give you any more than you need, and it's all based on the child's weight. Babies are always growing, so again, we do that a week or 2 or 3 in advance. Well, this alone isn't going to give the nurse or the practice everything they need to manage this tool. I'm going a little backwards, so I apologize. What they really need, along with this, is the ability to see all of their patients at once in the same place. So Dr. Grunmeyer modified an existing patient list feature of the EMR and gave it, again, new capabilities. So the first thing he did was we applied our RSV Synagis rules, and we populate the list for each practice with any and all patients they've ever seen who meets the criteria for that season. This is critical because the biggest fear of everyone seems to be that we cannot miss a single patient, nor do we want to see a patient too late, for example, in November, where it's too late to get them approved for their first or even their second dose. So that takes care of that. Another thing happening here with the list, which I really haven't talked about, is though we've translated the rules or the document into rules, that doesn't mean everyone agrees on it. Many times, every single year at every practice, doctors have particular patients they feel are at risk but yet aren't covered by the criteria, and they want to submit them for approval as well. Sometimes they're approved, sometimes they're not. Who knows why? It seems that insurance coverage is a factor. and there's different interpretations of the guideline. So we allow them to manually add any patient they want to the list, and by doing that, they get the benefit of the other tool. The rest of these columns here represent information entered on that individual patient tool. Actually, once you're approved, you really don't need to use that tool anymore. But by doing that, we now have created a new sort of care coordination communication tool beyond the capabilities of this notebook. So anybody in the practice can now log into the list, nurse, doctor, or clerk, and not just check on the status of any patient, but hopefully maybe even participate and share some of the responsibility and effort in managing all of these patients. Results. RSV season just ended last month, so we haven't yet compiled all the results, though early data seems to show the tool had a positive impact. We'll, of course, look into that more and publish the results. However, one thing we know for sure is that socioeconomics will continue to be a major factor in poor outcomes. And this is important because where does this occur? In our urban practices who have the most patients to manage and therefore the most burdened synergist nurse. To support all this, I went out and talked to some of the practices. We've had this deployed to 20 of our practices. I talked about 4 or 5 so far about their experience. And I have some late adopter and early adopter feedback. On the late adopter side, one of the nurses was particularly interesting. She liked the tool, she used it, but initially she did not trust it. So she used her notebook too. She used both. Talk about a guilt trip. Fortunately, it was a very low-volume practice. However, we seem to have passed her test, and she said that next year, if the tool provided, she would use it alone. By contrast, one of our early adopters was a nurse who was a former EMR champion. She worked at the clinic with the most patients, 87 patients on her list, though not all, of course, were approved or met the criteria, and she was able to use the tool exclusively. She eliminated her Synagis binder to this shown here, her new Synagis folder, which hardly contains any patient information at all. It has mostly phone numbers and insurance schedules and things like that. So, along with that and the latest upgrade in the EMR and some things we've learned on our own, we feel we can continue to make improvements to the tool and that we think it could and should be adopted by almost every nurse. So now to wrap things up, I want to return to my opening theme about consensus. And the real issue with this project wasn't our shared consensus or meaning on CDS, it was on the shared consensus or the lack of on the RSV Synagis criteria. And that for nurses, doctors, parents, drug companies, and insurance companies, there's a lot of confusion and a lot of disagreement, and this, of course, creates a negative impact for everybody. Most importantly to our patients, least importantly to us who are trying to create a nice, elegant application for a very inelegant process. So to help promote consensus on RSV Synagis, the project has a few sort of outreach activities and hopefully many more to follow. First, one of our pediatricians, Dr. Anik Hogan, who worked in the project, is presenting tomorrow at the PAS conference on our initial analysis of RSV Synagis outcomes and the poor outcomes to bring more attention to this issue. Second, one of our preemie experts who worked on the project went to the CDC last year, and along with a lot of people from all over the country, pushed and read a statement for more rigorous Synagis trials, palivizumab trials. And third, finally, the Glides project, as part of their work, takes exactly this kind of experience and goes back to the guideline authors to help them understand the sort of downstream impact of this ambiguous language that might occur in the documents, and that if they have the data, they need to use the most precise language possible. That will help all these different humans reading the document. It'll help us translate these types of documents into CDS tools. And who knows, it might even help Watson, because there's something like 3,000, 5,000 guidelines to date. Maybe if he wants to get in that business and translate these things, he could help out as well. Okay, that's the end of my presentation. If any questions, please feel free to ask. Going once.